Okay, well, welcome to everyone. So we're going to talk about colesteatoma, and this is an overview of the topic. It's really quite a big topic, and in fact, many of the sort of individual bits you could give a whole lecture or have a whole study day on each bit. But we'll hopefully run over the basics. What I've done at the Royal London is I've asked our registrars and SHOs to give me some questions, so bits that they don't understand. So we're going to put that in at the end. I'm going to hopefully try and answer some of those, and hopefully that'll be useful. So I think we showed this slide last time with laryngoplasty. So chronic otitis media is divided up into healed chronic otitis media, so that's usually a healed perforation, inactive mucosal, a perforation, inactive squamous, which is a retraction pocket, active mucosal, which is a discharging perforation, and active squamous, which is colesteatoma. Okay, so what we're dealing with is skin in the wrong place. And down at the bottom there's a small slide here, and you can see the sort of traditional East London ear with a combination of a retraction, mucosal disease, and this attic colesteatoma. Today we're going to talk about acquired colesteatoma. We're not going to talk about congenital colesteatoma. Congenital colesteatoma is often diagnosed in children and appears as a pearly white mass in the anterior superior portion of the drum. But we're going to talk about acquired disease, and most, or maybe all of them, probably develop from retraction. Sometimes you get a retraction and the drum can heal up behind it. Okay, so there are some cases where you look at the drum and you think, well, this doesn't actually look too bad, but there's a colesteatoma that's formed behind it where the drum is actually healed in front of it. And it's probably all to do with a failure of epithelial migration. That's how the skin starts to build up and starts to damage things. And there's bone resorption and bone destruction. And there's a wide spectrum of disease, from really very small retractions with a bit of colesteatoma to massive colesteatoma destroying the temporal bone. The other thing that's probably responsible for it, and we'll come and talk about this later on, is about eustachian tube dysfunction, and probably the majority of these patients have eustachian tube dysfunction. It may be that their eustachian tube dysfunction has actually improved, but that the disease has started and is developing, and that may have some relevance for the way you're going to reconstruct or put it back together. So what gets damaged with colesteatoma? I mean, the most obvious thing are the ossicles, and the commonest ossicle to get damaged is the long process of the incus. So that's the thing that you'll see that gets damaged most of the time. The malleus, interestingly, is usually pretty well preserved. The body of the incus may remain for quite a long time, and you can often find that within a colesteatoma sac. And then the stapes gets damaged variably depending upon where the colesteatoma is, and also probably with how much surrounding inflammation. So again, you've got some colesteatomas that are dry, and they may be indolent and nothing much may happen over a period of time. And then a wet colesteatoma where there's ongoing infection, you get bone resorption and probably much more damage with that. So after the ossicles get damaged, usually the commonest next thing to go is the labyrinth, and it usually starts off with a fistula of the lateral semicircular canal. And these patients may end up with labyrinthine fistula. It doesn't have to be the lateral canal, it can be the superior canal, it can be the posterior canal, but it's the lateral canal where the disease gradually erodes backwards that usually bears the brunt of labyrinthine damage. The facial nerve can certainly be damaged. Usually that's relatively late. We know the facial nerve is quite resistant to pressure, but again, that's one of the things that can happen. And you will see patients who present with a discharging or suppurative ear, and they may well have a grade 2 or even a grade 3 facial nerve palsy, and that indicates to you that really treatment should be very rapid. We mentioned the chorda. The chorda, as you know, runs across from the facial nerve across the middle ear, supplying taste to the anterior 2/3 of the tongue. That often is damaged, but usually patients don't notice that, I mean, the taste disturbance is pretty rare as a symptom to present with this. And often they do notice it when you divide it or injure it during surgery. And then the tegmen, the roof of the middle ear, can be eroded. And quite often you may see some bone loss and exposure of dura in that area. Most of the time it doesn't seem to give any problem, but it can do, and you can get descent of the dura, or even with brain contents within that. So what are the complications of colesteatoma? I mean, they're divided into extracranial and intracranial. So the extracranial, the first one is probably sensory neural hearing loss, which is really a complication of colesteatoma. Conductive hearing loss really is a consequence, it's not a complication. Sensory neural hearing loss, however, with repeated infections, as you can probably imagine, it's not so good for the inner ear, and you gradually see some hearing loss in an affected ear, and you can tell that it's really related to the colesteatoma infection if you compare it with the other ear. Labyrinthine complications, we've spoken about fistula, and you can get invagination of colesteatoma within the labyrinth, and therefore loss of vestibular function or irritation of vestibular function. Facial palsy, and then the abscesses. So these are usually pretty rare in UK practice. Postauricular, so behind the ear, the colesteatoma can actually erode out through here. A Bezold's abscess, which is along sternomastoid, and Citelli's abscess, which is along the digastric. Again, these are rare, and the treatment for this is probably to drain the abscess, but also you're going to have to deal with an underlying colesteatoma. So the intracranial complications are probably more severe. Meningitis, the first one, extradural abscess, so lying outside the dura, a subdural abscess, again within the dura, and then a brain abscess, cerebellar or temporal lobe. And again, these are all rare in UK practice, but they are still happening. Venous sinus thrombosis is when colesteatoma has usually irritated there's an abscess within the temporal bone itself, and you get thrombosis of the venous sinuses that may lead to the condition of otitic hydrocephalus, where the pressure may rise within the brain. Venous sinus thrombosis, if there's actually an abscess within the venous sinus, you probably do need to drain that and open it. And then treatment with blood thinning medication is required for a period of time. So this patient, you can see here this large abscess that's in the temporal lobe. And this patient was due to come in for an exploration of his ear, and he'd sort of been a bit unwell and obtunded for about 10 days beforehand. He'd actually had 3 contacts with healthcare professionals. And when he came for his operation, some of you who work with me will remember this, we sort of thought he's really not quite right. And that led us to send him off to the CT scanner, where we discovered this very large abscess. And what happens with this, the next thing that happens with this is basically it bursts into the ventricles. You get a ventriculitis, and that's got a really very high mortality rate. So this patient was treated with a craniotomy. So the abscess is drained by the neurosurgeons, and then at the same time, we also operated on his ear and removed his colesteatoma. We had another one recently, which again presented with a brain abscess that was dealt with in the middle of the night. And what happened on this occasion, it wasn't a specialist otologist who was on call, and it was reasonably felt appropriate not to proceed with ear surgery in the middle of the night. But a few days later, essentially again, we did a mastoid exploration and removed his colesteatoma. So that's probably the best way to play it. I mean, dealing with the ear is probably a 2 or 3 hour procedure, and doing that in the middle of the night may not be best. So where do colesteatoma develop? I mean, basically in the anterior and posterior epitympanum, in the pars flaccida, or in the posterior mesotympanum in the pars tensa, is where the vast majority will develop. I mean, the chance of developing in the anterior pars tensa is really virtually 0. So here's some imaging, some pictures. and this is the posterior epitympanum. So in the attic up here, the colesteatoma has started, and it's gone backwards here through the attic into the antrum, and really into the mastoid cavity. And then it's also gone down and underneath. So sometimes when you look at a drum, you can see under here a whitish structure, and that is the sac of colesteatoma. So that's the posterior. Posterior mesotympanum, again, it's developed in the pars tensor, and then has moved upwards here and moved up into the attic. Sometimes it's not so easy to actually tell where they've come from. The anterior epitympanum is where there's an anterior retraction that then goes in here and tends to fill the anterior attic, and then gradually works its way posteriorly over the ossicles. So here's a picture of an attic retraction. Okay, the rest of the drum doesn't actually look too bad. There's the annulus going around there, the handle of the malleus, the umbo here, probably a bit retracted. And this is the sort of thing which I think most of the time you would tend to observe this. There's probably not too much to be gained by operating on this. It really would be rather more a cosmetic operation. Here is a posterior mesotympanum colesteatoma. So again, it's skin in the wrong place. There's the lateral process of the malleus and the handle of the malleus and the umbo, the anterior part of the drum and the annulus here, a bit of debris down here. You can see how the drum is retracted here onto the promontory. There is the round window, and the colesteatoma is filling here. So almost certainly the long process of the incus has gone. It's difficult for us to tell whether or not the stapes will have gone, but it may well have done. And what you don't really know is how far backwards this is going. Again, another example of an East London ear, bit of debris here. Again, this is the left ear, this is the front of the ear, this is the annulus running around here, it's a bit rotated, and you've got a mass of colesteatoma. Really, so there's an anterior attic retraction, and there's a posterior mesotympanum colesteatoma here. And again, you just don't know how far back it's going here. Here, there's been some bone resorption. So the bone has been lost. It looks more to be a posterior epitympanic colesteatoma, with colesteatoma finishing here. This is actually the same picture as we saw earlier. Again, there's the malleus. This is the left ear. This is the front of the ear. The drum is here. It's either retracted or there's a perforation in here, and he's probably got coexisting mucosal middle ear disease. Some of that, however, may be driven by the fact that he's also got this active process going on here. And when we take that crust off, you can see there's basically skin here, and it's not possible to remove all that in the outpatients. So an important point to remember is always beware the attic crust. I mean, basically an attic crust is colesteatoma until you can prove it otherwise. An attic crust. Okay, this is colesteatoma underlying it. It's possible, you can see just here, it looks a bit white there. That could be colesteatoma going down there. There's the long process of the incus, and you can basically assume the stapes superstructure is going to be intact there. But what you don't know is how far back this disease is going here. And again, a very much more anterior epitympanic problem, a crust here. And again, this is probably quite a limited disease, but it's going under the handle of the malleus. And these can be actually really quite difficult to deal with. This bit of the drum, the back bit, is much easier to get to. The front bit of the drum, because you've got the malleus in the way, you have to make a decision about whether or not you can work around it, or whether or not you're going to need to, in fact, remove the malleus. So what's the symptomatology of colesteatoma? Well, it's highly variable. I mean, there are only 5 symptoms of ear disease. Usually you get 3 of them. You usually get hearing loss, but again, you may not. Patients with colesteatoma may have their hearing quite well preserved until later on when there's been some ossicular damage. And sometimes, even without ossicular damage, you may find that the colesteatoma bridges the gap so that the hearing can be maintained until quite late on. Discharge is probably the commonest symptom that starts. Pain goes with the discharge with infection and so on. But if you've got a discharging ear, if the ear is discharging, there's something wrong with it. And you maybe just otitis externa, maybe an otitis media with a perforation, but you've always got to think about the possibility of whether or not you've got colesteatoma, because the colesteatoma is a condition that is progressive and needs to be dealt with. So the preoperative investigations. When I first started, people did seem to do something called an EUA, an examination under anaesthetic, and I think it's extremely rare that you need to do an EUA now. Probably in children, it may occasionally have a role, but you're really going to use imaging as well. But in most adults, you should be able to examine the ear under the microscope and get a good view of what's going on. Pure tone audiogram is certainly useful to know what the thresholds are of the inner ear and what the hearing's like, and it will give you some clue as to the ossicular status. There's been debate for quite a long time. Some of you may have been on the Lion conference, where there were some senior surgeons who said that they wouldn't do a CT scan of the ear. I think in the UK, I think if you went to the exam and said, I'm going to examine the patient and then I'm going to do an operation, I think you'd probably get shot down. And I think if you said I'd always do a CT scan, not to diagnose colesteatoma, but when you know you've got colesteatoma, I'm going to do a CT scan to ascertain if there is any suggestion of erosion of the inner ear, and to look at the extent of pneumatization, because that's probably going to guide the way that we're going to operate. I've mentioned MRI here, so the non-EPI, non-echoplanar imaging with diffusion weighting is a relatively new technique, and it's pretty good sensitivity and specificity for identifying what exactly is colesteatoma when you can't see it. I think some of the radiologists would love us to do this on all of the patients with colesteatoma, but I wouldn't say that's part of the standard workup now. It, however, has got a big role in post-operative management and following up of patients. So here's an audiogram. So we'll say the left ear is affected. So these are the left ear air conduction thresholds. There's the bone thresholds essentially maintained. Looks like a Carhart's notch. You could say this would be, could even be compatible with otosclerosis, but often, even with colesteatoma, you see a little bit of a dip at 2 kilohertz. And he's got a mild conductive hearing loss. So you could reasonably assume that the ossicles are not going to be too damaged, but they may be damaged. But that would mean that you would approach the operation certainly with care, because one of the things you don't want to do is you don't want to drill the ossicles, particularly in the face of an intact ossicular chain. That's probably one way to give you a sensory neural hearing loss. I tend not to do this, but there are some people who would always go and look at the ISJ and, if necessary, divide it before proceeding with some of the surgery. And again, so these are both left ears. This is not a right and a left ear. These are both left ears. And this again is the sort of audiogram that you might find of someone who's got an intact ossicular chain. Here, this quite big. So here at 2 kilohertz, you may think, oh well, it's there's not much of a conductive loss, but this big loss here certainly suggests that there's likely to be some ossicular discontinuity. And this audiogram is an example, probably. So what we haven't got here is we haven't got the other side. And it can be difficult if you've got a bilateral conductive loss to establish exactly what the inner ear thresholds are, because of something called the masking dilemma. So if you've got conductive loss in both ears, you can't put a big enough masking noise into the non-test ear to mask it out. So therefore here we haven't really got any idea. You see the little arrow here? That means that they haven't reached the thresholds. They have here, and it's possible this is just a very big conductive loss. But you may not be so certain as to what the inner ear thresholds are on this side. So CT scanning, this top one here, this is actually this is the same patient, so both ears. So this is a normal ear on this side, and on this side, you'd probably want to know about this. So the actual lateral canal looks okay. This ear is fully opacified, and there's a cochlear fistula here. So, I mean, when asked if you ever regret doing a CT scan, the answer is probably no. But if you have ever regretted not doing a CT scan, and I think you probably want to know about this beforehand. I certainly remember early on operating on someone. It was during the time we were particularly keen on preserving the ossicles, and I remember dissecting over the top of the incus and dissecting down and down. I thought there's definitely a lot of room here between the incus and the medial wall of the middle ear. And in fact, what happened was that the colesteatoma had eroded the top part of the lateral semicircular canal. Now, fortunately, everything turned out fine, but it was a few sweaty moments that I would have been warned about if I'd got a CT scan preoperatively. And again, the other reason why you might want to do a CT scan is to look at the extent of pneumatization. So here's an ear with, there's the TMJ. This is relatively low down in it. There's the drum, and there's the facial nerve. And this is really not very pneumatized at all. Okay. Whereas in this ear, you've got a lot of pneumatization. And that's a big temporal bone. I mean, to be fair, there's actually no sign of disease in this, but it may well be that higher up in the attic there is some disease. But this would, you might be thinking closed cavity, combined approach to tympanoplasty for this. So what are the treatment options? Well, you can treat some of these medically and outpatient based. So you can clean out retraction pockets and very small cholesteatomas. If you have very elderly patients who are not fit for surgery, you may just be able to manage it, or I mean, to some extent you're saying, well, we'll wait and see what happens. But generally, the treatment is surgical. So the rules of cholesteatoma is the diagnosis is clinical and the treatment is surgical. As in everything in medicine, it's not an always or a never, but if you think of this as a basis, you probably won't go too far wrong. And what are the goals of treatment? The goals of treatment are a dry, safe hearing ear, if you can do it. Certainly, again, when I first started as a consultant, I was quite keen to make sure that everything was fine and that the ears were all dry, but I didn't pay that much attention to the hearing. And some of this, I think, came about because people were a bit negative about ossiculoplasty in some of the training that I had up to that. But I think it's probably always worthwhile considering the hearing, and it'll depend very much upon what the other ear is like. But a lot of these patients actually have bilateral disease. If you've got a completely normal ear on one side, then improving the hearing from very bad to bad probably doesn't make too much difference. But if you could make a worse ear a better ear, people particularly appreciate that. So we spoke about treating complications, so things like intracranial abscesses or extracranial abscesses need to be treated first of all. But then the idea of cholesteatoma surgery, basically you've got to get the skin out. So you've got to remove the diseased tissue, and then to obtain a dry ear, so try and prevent it from recurring or relapsing. And then if you can maintain improved hearing, we mentioned about preserving normal anatomy. And it's certainly the less anatomy you can disturb, the better, to some extent. I mean, this is one of the advantages of endoscopic ear surgery, is it does tend to preserve the normal anatomy, and you can look around corners. But sometimes some of the normal anatomy may need to be improved. So, for example, making the meatus bigger, improving the meatus, and also preventing the drum from retracting back. So from doing your nice operation, but building a house on sand, and essentially a year later, you've just developed the same thing again. So this is the bit that I think that many of the trainees find a bit difficult conceptually. So CWD means canal wall down, and basically you start with an atticotomy, You then gradually work back to an atticoantrostomy, and then you end up with MRM, which stands for modified radical mastoidectomy, which for a long time was the sort of the surgical standard of cholesteatoma surgery. So this is option, and then all of this is including reconstruction of the cavity and the ossicles. Now there is also a debate about whether or not if you actually reconstruct your cavity, you're almost moving it a bit back towards a canal wall up procedure, which may have some implications for the way you're going to follow them up. And then canal wall up, I mean the classic canal wall up is a CAT, a CAT, or a combined approach tympanoplasty. And what that essentially means is that you're working through the mastoid and down the ear canal at the same time. But essentially, you've kept the posterior canal wall intact, and this helps with your reconstruction. So canal wall down. How are we doing? Moving on. What are the advantages of canal wall down? The cavity is visible, so you can inspect the cavity and you can look at it afterwards. That's a good thing. That may also be a bad thing because you may end up with a cavity that may discharge. It probably is technically easier to do a canal wall down procedure. There are some difficulties with a CAT that we'll come on to talk about. The other advantage of a canal wall down is essentially it follows the extent of the disease, so you don't need to do more drilling or remove more tissue than the disease has dictated to you. And the figures are that recurrent and residual disease rates are lower. They're not zero, they're just lower. The disadvantages is that it may be a bit more difficult to reconstruct hearing, maybe, and you do end up with this cavity. And one of the problems can be, essentially, you don't want too big a cavity. You want a relatively small cavity, and you want it to be shaped such that there aren't any sumps or any bits where water or wax or stuff can collect. These patients will also have the disadvantage of probably needing to be followed up and having their ears cleared out from time to time, and those time may vary. Part of the technical aspects is when you're doing a canal wall down is to make your cavity ideally as small as possible, and to shape it such that it looks like the wax is going to migrate outwards, because that's the big problem, is the failure of epithelial migration. So we might call this small cavity. The problem is also that there are lots and lots of different names of what people call these things. Small cavity mastoidectomy is a disease, therefore limits the dissection. The approach, you can do it post-oral, you can do it endoral. Many of my previous registrars will know that probably one of my favorite go-to treatments is an endoral small cavity inside-out mastoidectomy. The post-oral may give a slightly cosmetically better outcome, although, to be honest, the endoral scar usually heals extremely well. You may have to be careful in Afro-Caribbean skin. I have seen some patients who developed keloid in that. And the post-oral does give you better access to the cortex and to the mastoid. However, with the endoral approach, you can actually, you can actually continue it over the top and move the ear back a long way, and you can probably get all the way down to the mastoid tip. And the other good thing about the endoral is that the meatoplasty is part of the approach. So making the ear canal bigger helps with the post-operative management of these patients. It also helps to provide some ventilation to the ear as well. And that's an important part of surgery. The advantage of endoscopic surgery, which is essentially a permeatal small cavity inside-out mastoidectomy, is that you don't have all of the previous excisions, but you do have to get some tissue from somewhere. So this again is an endoral incision, intercartilaginous incision, and then this incision goes down the ear canal more towards the front of it, and by doing this you actually expose all of the tragal cartilage which you may wish to use to reconstruct. Post-oral incision, this is a picture that we showed last time with the laryngoplasty. Don't do the red one. That one there is more difficult to heal up and doesn't give you as much access. And if you're going to do a post-oral incision, that or even the blue one heals up perfectly fine. It heals up cosmetically very well. Usually is in the hairline if you've got some hair, and is easy to sew up because it's on a flat bit and gives you lots and lots of access. So the step one is the initial incision, as we've spoken about, and taking some fascia. So you're going to want to reconstruct the ear. And temporalis fascia has been around forever. It's easy to work with. It's easy to get lots and lots of it. And I think is what you're going to use for most of it. Cartilage is also helpful, but I tend to use cartilage and then with fascia over the top of it to try and ensure that the epithelium migrates over it. A canalplasty, so enlarging the bony canal, certainly helps to get a good view. And then you tend to elevate the drum. We mentioned about looking at the ISJ to see if it's intact or not. And then basically you start drilling by removing some of the attic and then gradually going backwards and backwards to the posterior extent of the disease. What do you do about the ossicles? So in the most classic colesteatoma surgery, you have a often the ISJ, the often long press of the incus is gone. So you take the body of the incus out, and then usually it's worthwhile taking off the head of the malleus just above tensor tympani. So you go through the neck of the malleus. The advantage of that is it gives you access to the anterior epitympanum, and you can check whether disease is there or not. And then once you've got adequate exposure, you remove the disease. So I did do some work with Rupert Obholzer and Jay Ahmed quite a long time ago when we looked at what happens if you keep the ossicles intact or if you take them out, and the results really weren't very different. You can reconstruct the hearing. The results are not as good as anything such as stapedectomy, but you can make the hearing better, and we found there wasn't much difference. So I think it's worthwhile, if you can, preserving the ossicles. But if you have to, if the disease is on the other side of them, and the problem even with the endoscope is it can sort of see around corners, but you need to remove quite a lot of bone to be able to do that, and you need to be able to get around there to get it out. So I wouldn't worry too much if there's any doubt, then basically take the incus out and reconstruct the disease at the end, and then you remove the disease. So this is a normal ear. This is not an ear with a colesteatoma. This is a left ear. This is the front. Okay, and then you might start by drilling in this area here, maybe a bit more forward here, and you always sort of start and hope that you're just going to find a little colesteatoma, but usually it goes back and then it goes back, and it may well be, if you're lucky, with an incision like that and removing that bone, then you may be able to get to the extent of the disease, but often you have to continue backwards. And here, one of the things to do is to start to shape the cavity by removing some of this bone here, because you're going to want to have the cavity without a sump. You may have heard of something called the facial ridge. The facial ridge is basically an inadequately lowered posterior canal wall. Okay, the facial nerve is not out here. The facial nerve is further in here, and leaving a big lump of bone here because you're worried about the facial nerve is a mistake, because this is what leads to sumps in this area here. So the problem areas are the sinus tympani. The sinus tympani is the bit that basically lies on the far side of the descending facial nerve. The stapes and footplate. And the problem can be is that you can have disease through the arch of the stapes, and it can be really quite difficult to remove it. The problem is that if you have a stapes, you're hearing out an intact stapes, your hearing outcome results are definitely going to be better than if you don't have that stapes arch. And therefore, I might spend quite a lot of time seeing if I can remove the skin from the stapes. I mean, if there's doubt, then you may need to use the laser. You may need to, well, I would use the laser. You can divide the stapes crust, but often, I mean, the stapes is not fixed, so it's a bit mobile, and the risk is that you pull the foot plate out, but you can divide the crura, but using the laser makes this much, much easier. And then take it off. The anterior epitympanum can be difficult to get to. And again, you might have to remove quite a lot of bone. But the good news is that there's not too much of troublesome obstacles in the way in the anterior epitympanum. The main danger would be going too high and exposing the dura or going into the middle fossa. And the TMJ can occasionally get in the ear. We've mentioned about the medial side of the ossicles. If you can't see it, it's very difficult to remove the skin. And the sinodural angle is really just it's just when you have to go back a very, very long way. This is a slightly random picture, but I put it up because it's such a nice dissection. So again, this is a left ear. This is a temporal bone picture. And here is the facial nerve. Okay. Here's the drum. It's been left intact. The malleus has been left here, the handle of the malleus. The head of the malleus has been truncated. There's no incus. The stapes has been removed. There's in fact, I think that probably looks like an open oval window there. Okay. But to identify the facial nerve, there are some bony knobs that you can follow. And the first one is the cochleariformis process, where tensor tympani comes out. Second big bony knob is the lateral semicircular canal. Third bony knob that's here is the stapes, and then the pyramid. All right. So this is the thing that we don't want to drill into. Reshma or Anna, I don't know if there are any questions so far.
Okay, so one question was, what do you mean by the extent of pneumatization? I think you did touch on that, and specifically, I noticed, like you said, that poor pneumatization would make you consider an open cavity. And why is that?
Well, so pneumatization means basically how much air there is within the temporal bone, and there are some. So if you do a translab, for example, so an acoustic neuroma, usually these patients don't have any ear disease, and they often have very pneumatized temporal bones. It's a bit like the sinuses. Sometimes patients may have an absent frontal sinus, or they may have a massive frontal sinus. Same thing happens in the temporal bone, in that you get varying degrees of pneumatization. And often, if you've got a patient who's had chronic otitis media, and again, most of these problems start in childhood, they have poor pneumatization. So at the most extreme, you end up with just an antrum. So that's the extreme. You always have an antrum, but then you don't have any other pneumatization. And if you've got colesteatoma, it really needs to go. It really needs to go through pneumatized bone. It's unlikely to erode unpneumatized bone. So that's what we mean by the degree of pneumatization. And when I say an open cavity, what I really mean by open cavity, from my thinking, is a small cavity inside out mastoidectomy. So you start at the back, start at the front, and you go backwards. Whereas conceptually, the different operation is to do a combined approach tympanoplasty, where you make your incision behind the ear, you drill the mastoid out, you do a cortical mastoidectomy. I mean, we're going to come on to this in a minute. You do a cortical mastoidectomy, and you expose the attic, and you also look down the ear canal, and you're aiming to preserve that posterior canal wall, which means you don't have a cavity in the end of it. But again, the disadvantage is you've gone through quite a lot of normal tissue before you get to the disease.
Would you perform an ossiculoplasty during the primary colesteatoma surgery? How would you decide that?
Yeah, the answer to that is yes. We'll come on to talk about that.
Okay. Can you tell us about the anatomical area around the epitympanum?
The what?
Anatomical bony area around the epitympanum.
I haven't really pictured that. I mean, there's this is the anterior epitympanum here. And there are some folds. There's the tentor tympani, and there's a relatively variable area of the sort of supratubal recess in this area. I mean, essentially during the surgery, I mean, once you take the malleus out, you can sort of see the extent of it, and you can follow the disease. As long as you don't drill into the facial nerve, which tends to run here, then there's quite a lot of room in this area here. But the most important thing is to get access to it. So that means that when you're doing your atticotomy, you often need to take the skin off quite a long way forward, so you can get access to the bone to drill out the anterior epitympanum. All right. I don't know if I've answered that or not, but anyway.
Okay, and the last question that I don't think you're going to move on to, which is, how can you predict extracranial complications, essentially? Can you, by looking at the colesteatoma?
No.
How long does it take?
No, you can't. I mean, Anna and you will probably remember the most recent case we had of the temporal lobe abscess of someone who basically had a very small colesteatoma. In a very small colesteatoma. I mean, what might predict getting extracranial complications is if it's discharging a lot. So if they've got lots and lots of pus coming out, they've obviously got active infection, and there is a risk that goes inwards. But essentially, I think when you look at the eardrum and the ear canal, it's probably not that possible to predict. I mean, that's the advantage of doing a CT scan. You know, you get a better idea of the rest of the temporal bone anatomy.
Okay.
So the simple answer is, I don't think, you know, and again, I've seen a child recently who had a really pretty small colesteatoma, but it was wedged between the incus and the facial nerve, and he started to develop some facial nerve weakness. So there's no way of predicting it. I think colesteatoma is a disease that needs to be dealt with. So that's the way to think about it, I think. Okay,
thank you. I'll let you carry on.
Okay, so one of the questions that comes later is about this area here. So here's the ear canal. Okay, so this is a right ear. There's the front here, the back here. There's the malleus. There's the incus. And there are these two areas here. And amazingly, this is posterior mesenteric colesteatoma. I put this picture up, and then I suddenly realized I'd actually labeled the two areas wrong. So this is the facial recess, otherwise known as what we in the UK tend to call the posterior tympanotomy, but the facial recess approach. So this is lateral to the facial nerve and to the stapedius muscle that lies within the pyramid. And then the sinus tympani is this area here. And this is a variable area. And these are the problem areas. These are the difficult areas. This one isn't. But this area here is sometimes difficult to get at. This is where endoscopes certainly can be helpful if you've got a deep sinus tympani to see round the corner. So anyway, after you've taken it all apart, you then have to put it back together again. And we've spoken, temporalis fascia is what I like to use to line the cavity. And ideally, you want all the bone to be covered such that the epithelium, the skin, can grow across. It's always worthwhile being careful with your canal wall skin. I mean, really, you don't want to lose any canal wall skin, okay, because that will also help with the epithelialization. If you haven't got temporalis, I mean, the big problem is if you haven't got temporalis fascia, what are the alternatives? Alternative one is the subtemporal periosteum. So underneath temporalis, if you lift temporalis up, there's a beautiful layer here, which is the pericranium or periosteum, and that can be taken off as a free graft, or you can swing it down. I mean, you can't get it down that far, but you can swing it down as a pedicle graft, and it does have some vascularity. So that's one very good alternative. Perichondrium is a good alternative, but you may have some difficulty getting a lot of it. So you can get quite a lot of perichondrium from the tragus here. And then cavity minimization. So it's rare that I probably wouldn't use some cartilage or even potentially some bone pate. Particularly even if you've done an atticotomy, you want to avoid the risk of essentially the retraction reforming and it going back through your antrum. And I would tend to block that up with cartilage. And now I'm more likely to tend to use some bone pate as well. I sort of have always thought that bone pate is better off covered with, again, vascular tissue, and that would be the subtemporal pericranium. But I'm aware that other people just use free graft, so like fascia, with bone pate, and these are good ways of making your cavity smaller. It's very, very flexible to use. I don't use any external sourced material apart from titanium for ossiculoplasty. So things like hydroxyapatite cement, some people do use. I mean, there's no shortage of bone that you can get from around the ear. And you tend to draw the bone out and collect it up. You can use a sucker and a bone pate collector, or you can just pick it up. You want to avoid getting any skin with it, and you don't want it to be too wet. And I would always put some antibiotics. I would always put some ciprofloxacin in it before using it at the end. Some of you will probably be aware of something called Sironicem. So Chris Aldrin, my friend and colleague in Wexham Park, used to obliterate his combined approach cavities with this Sironicem, which is a glass ionomer cement. But there was quite a very significant tissue reaction from that. So I tend not to use anything foreign apart from titanium. Where else can you get stuff from? You can get temporalis fascia from the other side. We've done that once. The other places you can get fascia is from the leg, from fascia lata. There are alternatives, things like Biodesign or Duragen are alternatives that I don't have any experience of. I've always used the patient's tissue. And hearing repair. So it's difficult to know sometimes what to do. It depends. It depends upon what the status of the ear is. I've got some remarkable results by just doing nothing. So you've got a stapes there. If you drill down enough to make the posterior canal wall relatively low, up to the level of the facial nerve, and your drum will probably lie on your stapes and may give you an excellent result, or at least a 15 decibel or maybe less air-bone gap result. However, if you think there's a gap, the alternatives are to just use some cartilage on the head or to use an ossiculoplasty. And this is the Kurtz Variac, which I quite like. These, as hopefully most of you will be aware, the advantage of this is that you can, this is a partial prosthesis. The first thing is that you can have a go with this plastic spacer beforehand to get the right size, and then you make the prosthesis. Here we've made it very, very short. And the newer thing that I'm using is this thing called the Dresden clip. So this clip sits on the head of the stapes and is really fantastic. I mean, you put it on and it just stays where it is. Disadvantage of the Variac is you know, it's a bit more mobile. These are really good. And if you haven't got a stapes head, then you can start to think about using a total prosthesis. Again, it all becomes a bit difficult. You've got the foot plate, you've got the prosthesis, you've got some cartilage on top of the prosthesis, and then you've got the drum as well, the reconstructed drum. So you've got quite a lot of variables in there, but it's certainly possible to get good results. I would essentially nearly always attempt some form of hearing reconstruction, although that attempted hearing reconstruction may be just putting the drum on the head of the stapes. But I think it's worthwhile doing it. And again, this is because we've gone away from the idea of second looks. No one is really probably doing a second look because now of the availability of non-EPI DWI. So these are a few patients. This chap, I mean, this looks pretty normal. This chap had a relatively small attic colesteatoma, and this is all reconstructed with cartilage. He, in fact, has just got a small piece of cartilage on his stapes head, and he's had an excellent result. In fact, I did this in about 2002, and I saw him recently, and the ear looks more or less the same. Another reconstructed drum. Again, you can see the cartilage a bit more clearly here. So I tend to, the cartilage you can use, one is you can use the cartilage from the tragus, and this is quite nice. The other stuff that's good is contral cartilage, but again, you need either a separate incision here, or you need to go behind the ear when you're doing a post-oral incision. And the advantage of the contral cartilage is it's got a natural curve to it, but I tend to use a number of different pieces. Okay, so here, there's probably a piece of cartilage down here. There's definitely a piece of cartilage here, and there'll be a piece of cartilage here underlying on top of an ossiculoplasty. This is when you've got a bit of a bigger cavity, and so there's the drum down here. There's the top of the truncated stump of the malleus, and the malleus down here. Again, this is the lateral semicircular canal, and he's got a bigger cavity. This may be one where we've just put some temporaneous fascia, but the shape of the cavity is really good, although you can see there's a bit of wax build up here. The other possibility is there was some reconstruction here, so there may have been some bone pate within here, and even some cartilage on top of it, and it may have resorbed over time, and that is what happens. This is effectively a modified radical mastoidectomy that started as a small cavity inside out mastoidectomy. We've not ended up with that smaller cavity. Here's the lateral semicircular canal. There is the stapes and the footplate. It's all retracted in. Okay, there's what's left of the drum. Facial nerve, you can see the vessel running across there. But basically this is a dry and safe cavity that doesn't create any trouble. This is a cavity where, again, the middle ear is not in good shape, and we've got a bit of a band here, so there is a danger of this building up. And I think what we probably did here is we probably tried to reconstruct this, but it has resorbed. Okay, so that's a cavity that may or may not be all right. So why do cavities discharge? Well, the first thing is to do with the shape of it. So if you get a mastoid sump, or this so-called facial ridge, and stuff builds up over there, then there's a good chance of it discharging. Often part of the problem is the cavity mucosalizes, so it doesn't epithelialize properly, and you get a wet mucosa within there. And if you get a perforation in the tympanic membrane remnant, it may continue to discharge. And then, of course, residual or recurrent disease and inadequate meautoplasty. So these are all things that can be corrected if you're thinking about revision surgery. So we move on to combined approach tympanoplasty or intact canal cord mastoidectomy. So the idea here, we've gone over it a bit already, but to keep the posterior canal wall intact, and you basically do a cortical mastoidectomy, and you go down the ear canal, lift the eardrum up. More difficult, you open the facial recess out. So the Americans call it a facial recess approach. We call it a posterior tympanotomy. And the important thing is that some ears are totally unsuited. If you've got a very poor pneumatization of the ear, then it really is extremely difficult. There's just not room. And this is why I think if someone says, I always do this, then that would be a mistake. You need to vary your approach. You need to have a different approach for different situations, which to some extent makes it more difficult. These are actually again temporal bone things. So this would be the start of a cat. So there's the ear canal there. Here's the cortical mastoidectomy that's been done. There's the incus there. So we've exposed the attic, and there's the lateral semicircular canal. And again, this is the facial recess approach. This is in this particular one, this is what you might do a bit more for a cochlear implant. But so this is the bridge, and here's the incus here. The malleus is there, all right, and you can just about make out the stapes tendon there. Now, usually in colesteatoma, as in this one here, the incus is out, and you would remove this bridge, and you get a fantastic view into the middle ear. But again, you might need to remove quite a lot of bone up here to get a good view to the anterior epitympanum. And again, telescopes may well be helpful within this. In this one here, there's the facial nerve. It's been exposed in its descending portion, and there's the cauda running across there. And in this, which is a much more extensive dissection, the semicircular canals have been blue lined, so you can see exactly where they are. And again, there's the facial nerve, and good view to the anterior epitymulum. And you can see how much drilling you may have to do to get all the way forward. So the advantages, it is more anatomical. It keeps the ear canal more normal, and it avoids cavity problems. And they tend to heal up really quickly. So, you know, if you've got all the epithelium of the ear canal covered, then it tends to you know, resolve very quickly. And it's possibly easier to reconstruct here. You've got a bit of a bigger gap to reconstruct with. But the disadvantages is a higher residual rate, recurrent disease. So you do an operation, it looks fantastic at the end. Trouble is, 6 months or a year later, it's just retracted back in again, and you're back to the same situation. And then there's the problem of a second look, but as we've spoken about, that's been superseded by the non-EPI DWI. And this is an example of this, and you can see here, colesteatoma shines up very bright. So it's a bit difficult on this transaxial MR to be certain what's colesteatoma, but the non-EPI DWI helps this. And most radiology departments will now do this for you. And essentially, that's why you wouldn't need to do a second look. But the newish things are, one is to obliterate the cortical mastoidectomy. So this is called a bony obliteration tympanoplasty, and is a Belgian concept. And you tend to basically just you put some fascia down, and you fill the mastoid cavity up with bone pate, and that again stops the retraction happening. You can use the laser. I think the laser is useful for certain situations. And there are some situations where I wouldn't advise using it. I probably wouldn't advise using it to get colesteatoma off the facial nerve. But in lots of other cases, it is a very useful technique. I use the KTP laser. And then endoscopes. I mean, I say newish. Endoscopes have been around for a long time, but they're great at looking around corners. And if you've got the endoscopic instruments from Storz, then you know you can also remove colesteatoma from hidden areas. We're going to move on to the, these are the questions that have been put down. I mean, the first one is not really a colesteatoma question, but it's what's your best approach to the management of external ear canal colesteatoma? So external ear canal colesteatoma is a pretty rare thing, but essentially you get an invagination of skin, and you get erosion and destruction of bone. And the treatment of that is really to get rid of all the abnormal skin, to open it all out. Again, instead of having a little dip like that, you have an open area, and to cover it with some fascia. So that's the way to manage that. In what circumstances would you get an MRI pre-op? Extremely rarely. So then the problem as the registrars will have is that you see these patients in the clinic and you're not really sure whether they've got colesteatoma or not. They've got a discharging ear. You know there's something wrong with them, but have they got a colesteatoma? I mean, rule one probably should be to get your boss to look at it, or one of your more senior colleagues to look at it, to decide whether you think they've got a colesteatoma or not. A CT scan is probably not going to, is a worthwhile investigation, but not for every chronic ear. So it's pretty rare I would get an MRI pre-op. I think if you're doing a lot of endoscopic surgery, then there may be some merit in seeing whether or not, because it's quite good to show exactly where the colesteatoma is, to see how much it goes back into the cavity, because that may alter what you're going to do beforehand. But again, if we've done a CT scan and it looks like it's a relatively capacious temporal bone, we're probably going to be thinking about doing a combined approach anyway. Would you change your approach technique if when operating on an only hearing ear? Well, the answer to that is no, because that suggests it's a bit like, would you do something better than you would normally do? And the answer is no, you'd normally do the best thing that you could do normally. So the approach is really very similar. You've again got to take the take the disease out, and you've got to reconstruct it as appropriately. So that's what I think. That's what I think about. I mean, the only issue that you might consider is about hearing reconstruction. So if you do an ossiculoplasty, probably not a port, but if you put a torp on, there probably is a slightly higher risk of getting a dead ear or damaging the foot plate. And the trouble is, on one hand, you're committing the patient to a bigger hearing loss, or you think you're committing them to bigger hearing loss. So that would be a difficult one. It would depend upon exact intraoperative approaches, but essentially the approach is the same. When would you choose to use a laser? I think this question pertains to using a laser to paint the cavity. So the concept of this is that when you've dissected the colesteatoma out, you may have left a few cells behind, and therefore going over it and lasering it will damage it. And sometimes I will do that if I think I've left some stuff behind, but really the ideal situation is to remove all the colesteatoma. Now, how you remove the colesteatoma, again, will depend upon what you may have available. I tend to do it with usually a relatively, something like a Hughes elevator, which is a relatively small elevator, but there can be some advantages of dissecting with the laser as well, and that tends to cover, tends to cover most things. But sometimes you can make your planes less easy to see when you start lasering. Now this is a good question, and there's another question a bit later on, which is about let's go back. Which is about the Eustachian tube, and someone asked, so why don't you just do a Eustachian, because this is probably all about the Eustachian tube, why don't you do a Eustachian tuboplasty? And the answer to that is, if a Eustachian tuboplasty was the answer to all Eustachian tube dysfunction problems, then yes, it might be worthwhile doing, but I think it's not. I have tried it on a few patients doing combined approach, and I'm certain it's made no difference, because these patients, they've been pretty tricky patients. They've had, disease where it's tended to recur, and it hasn't made any difference. So the problem with Eustachian tuboplasty is it probably isn't the solution to all Eustachian tube problems. Otherwise, addressing it, it probably is worthwhile removing mucosal disease in the Eustachian tube opening. If there's lots of thickened mucosa, it's probably worthwhile removing that. We said about doing a stage 1 ossiculoplasty versus delayed. Essentially, I would usually be thinking about improving the hearing. One of the reasons about delaying it is that you might get an idea of where the drum is going to lie in the future. But the problem is going back and reoperating on these patients is about as difficult as the first time you do it. So essentially, you're always thinking about whether or not you can improve the hearing at the time of surgery. But again, it depends upon what the other ear is like. How do you approach canal fistula? So the options are, option 1 is to leave skin over the top of it, and option 2 is to take the skin off. If you're doing a closed cavity, a combined approach to bandplasty, it seems to be pretty difficult to deliberately leave some skin over there, although the hope is that it sort of rolls up into a ball. Most of the time, I would be attempting to take the skin off and then repairing it. And for this, it can be quite tricky. Sometimes the skin comes off quite easily. Often with a fistula, there's just a little bit of blue lining. I think if you've got a very big fistula, it can be very, and you may know that preoperatively, it can be very difficult, and you probably would change your technique to have an open cavity approach. And to be honest, of course, they're probably likely to get quite good hearing. You will remember that one of the early treatments for otosclerosis was, in fact, the creation of a fistula. So fenestration is a fistula. So they can get pretty good hearing with that. But if you think it's small, if you think you can get it off, then you would essentially try not to damage the endosteum and separate the colesteatoma from it. And once you've got that there, I would then put some bone pate on it and I would put some fascia over the top of it. So that's what I would do. And I've seen patients in whom I've done that, and again early on gone back and looked, and the bone forms a new covering. The technique for removing chole off the facial nerve, again, is essentially sharp dissection. Actually, I haven't mentioned about facial nerve monitoring. I think you're probably sensible to use facial nerve monitoring for all cases of colesteatoma. In fact, I would strongly recommend that. And that will give you some clue as to removing the colesteatoma off it. This is about the medication that was mentioned again in Lyon by the people from Antwerp, but I don't think we don't seem to know what that is. When would you do a Camille down as a primary procedure? Again, that we've spoken about that. That would be when you look at it and you think, am I going to do a better job with the small cavity inside out, or should I do a combined approach? No graft material. We've again spoken about that. That's when you may go to the leg. Trouble with fascial lata is it's a bit thick, and that's when sometimes I suppose the things like biodesign may be worthwhile thinking about. This is a bit about doing a balloon tuboplasty. This question, if you think you've cleared all the disease, well, the answer is you think you've cleared all the disease. I mean, if you haven't cleared all the disease, then you haven't finished the operation. So really, you should try and make sure you've cleared all the disease. And then, yes, the answer is about obliteration. And we've spoken about cavity minimization. If you've ended up with quite a big cavity, then it probably is worthwhile thinking about. So I would always collect bone pate at the start of any procedure. It probably is worthwhile thinking about obliterating it. So yes, that's something I would do now. We've got these. So I hope I've sort of answered some of this about when the front to back anaticotomy. So the factors are the disease, the anatomy, and the pneumatization. Posterior tympanotomy we've discussed about. So the chasing the disease. I mean, the answer is you do chase the disease. You find the disease to remove it all, and that means getting adequate visualization. So that means removing enough bone so you can see where you're going. And I think that's the bit that probably as registrars, you may be worried about removing more bone, but the answer is as long as it's not a critical structure, then you should remove that bone so you can see what you're doing. We decide to take the ossicles out if we have to. Okay, so if you can't get the disease out without removing the ossicles, then you have to take the ossicles out. We've spoken about fascia and cartilage, so tend to use fascia. Cartilage, I tend to use cartilage underneath fascia, so the stuff epithelialized over it. Blind sac closure. So if some of you were on the training day yesterday, you'll have seen Neil Donnelly doing a blind sac closure. Blind sac closure is the nuclear treatment for colesteatoma. If you've got a dead ear, then it's certainly tempting to think about doing a blind sac closure. You just do a total lateral petrosectomy, but that's not usually what you would do to start with. But there are circumstances where you just think about doing a blind sac closure to try and sort of clear the problem. Okay, Reshma, I think I've finished.
Okay, fantastic. Thank you so much, Mr. Wareing, for helping simplify and demystify, obviously, an incredibly challenging topic. You okay? You're looking at the questions?
I'm looking at the questions. So we've got any drills compatible with endoscopes? The simple answer is I don't know. I think that's one of the problems of endoscopic surgery. There is a piezotome. So they are trying to develop stuff to remove bone. That's one of the limits of endoscopic surgery is you need to have a very strong right wrist to use that curette to get all the bone out. I mean, bone pate is highlighted differently, but it's different to recurrence and residual disease. So your radiologist should be able to ascertain the difference between them. I mean, again, the non-EPI DWI, it was from Jan Kasselman, again in Antwerp, where they've developed this bony obliteration tympanoplasty, so that they are confident they can tell the difference between colesteatoma and between the reconstruction. I mean, DWI probably won't. 3 millimeters is given as the limit of what you can identify. So sometimes, and we didn't really speak about the follow-up. People have got different ways. I tend to go, about 1 year, but I'm not usually too worried about the timing of it, and then maybe at 5 years. But again, you should examine the patient first of all, because you may see a recurrence, and then you don't need to do an MRI. If you can see it, you don't need to do it.
Is the SARD-TOS classification useful for describing retractions, or should we be moving towards just using routine otoendoscopy in clinic?
I think in an ideal world, taking a picture of an ear, uploading it to your system and having it for review in the future would be the ideal way of doing it. Because essentially the classification is a way of drawing the picture. I mean, I always tend to draw a picture, and then you might say if it's a grade 1, grade 2, grade 3, or grade 4 pars tensor retraction. So grade 1 is it's a bit retracted. Grade 2, it's onto the long process of the incus. Grade 3, it's onto the promontory, but can come off. And grade 4 is it's stuck on the promontory. And the trouble is, it's sometimes difficult to distinguish between grade 3 and grade 4 unless the patient is able to do a Valsalva. So I tend to draw a picture, but the answer to that is you're better off if you can, taking a picture of the ear. But otherwise, drawing a picture, everyone should be able to draw a picture of an ear, really. Right, Manny's asked, if you do an end or an inside out with cavity obliteration, bone dust, what's the disadvantage? He says, what's the disadvantage? There's lower recurrence rates and no cavity. It probably does have lower recurrence rates. I mean, this may talk about the fact that if you actually tend to put bone pate in, it may prevent, it may kill epithelial cells. But it's not got low recurrence rate. The disadvantage, Manny, is that you're putting this non-vital tissue in, this bone that's quite attractive to bacteria, and there is a risk of course of getting an infection afterwards. But yeah, I mean, I agree. I tend to prefer probably to put bone pate and then to put some cartilage over the top of it, and then to use some fascia. That would be my probably preferred technique. All right. How do we manage a fistula? I think we've spoken about that.
And the question from Ellie on the other chat side is, can you laser residual skin left over a canal fistula to stop it regrowing?
Can you relay the residual? Just give me that one again.
Can you laser residual skin left over a canal fistula to stop it growing?
I mean, you've made a choice to either leave the epithelium on the fistula. I mean, sometimes it can be difficult to know if you've got a fistula or not, because you've got epithelium over it. And it's only when you lift it up, you go, oh, there's a fistula. And you can put that back down again and just leave it there. All right. But if you've taken the skin off, then that's in the bin. So the answer is no, you wouldn't take the skin off and then put that skin back on. You would take the skin off, you would put some bone pate over it, and then you would put some fascia over the top of that.
Okay, that makes sense. And a last question from Claire is, how many years do you follow up patients with DWI MRIs?
I think that 5 years is more than reasonable.
A scan every year.
But I am aware that other people use scanning techniques that seem to last for ages. Again, in the Lion thing, we had Owen Officius, and they seem to do scans, every 1, 3, 5, and 7 years. Although he also said they don't have any recurrences, so I don't know what the point of that was. But
to prevent missing an intracranial Colesteatoma, I think he said.
He did. So, but I think 1 year or 5 years, but your department may have different views about this. But the clinical follow-up of the patients is also important. All right.
Okay,
Great.
fantastic. Thank you very much, Mr. Wareing.